Hello everybody. Today we are going to discuss about delirium. This was a question which was asked in DRNB critical care exam in October 2023. So the delirium is the neuropsychiatric complication commonly encountered into the intensive care unit. It has been found with incidence that ranges from the 5% to 92%. Delirium is consistently associated with the morbidity determinants such as a longer ICU length of stay, increased mechanical ventilation days, and the long-term cognitive dysfunction. So risk factor for the delirium. Delirium triggers in the ICU can be divided into two groups, that is baseline and the hospital related. The former are those intrinsic to the patient's characteristic and the comorbidity that can seldom be corrected. Hospital related factors are associated with the patient's underlying disease and the management. Measure to prevent and treat delirium focus on the altering the later, as hospital related risk factors are the usually modifiable. Delirium development threshold is inversely related to the patient's susceptibility. It might only take a minor insult for highly vulnerable patient to develop delirium. Pain is the most common and the preventable delirium trigger. Pain is not only an etiology, but it also leads to agitation promoting intervention that further enhance the delirium development. Pain must be appropriately assessed and managed in the process of delirium prevention. The Doloria study found in the ICU patients evaluated adequately for pain were less likely to receive delirium promoting drugs such as benzodiazepine and are more likely to receive analgesic medication. Immobility has been associated with the delirium development in the observational cohort study. Early mobilization research has assessed the relationship between early physical rehabilitation and delirium. The findings suggest that early mobility might play an essential role in reducing delirium duration among intensive care patients. Now, about assessment, elderly hospitalized patients that develop delirium end up with the higher mortality and admission to the long term care. Therefore, it is imperative to adequately assess delirium throughout the entire hospital stay for proper patient care. There are various objective scoring tools to complete this evaluation, and chosen instrument will depend upon the patient's population need and goals. One of these tools is the delirium triage screen. The delirium triage scheme was designed to be first step of two-step delirium diagnostic method. It rapidly rule out delirium in less than 30 seconds. It consists of assessing the level of consciousness via Richmond agitation sedation scale and the inattention. The delirium triad screen is positive if if RAS is other than 0 or patient commits more than one error spelling the word lunch backward. If positive, confirmatory second tool must rule in delirium. If negative due to its more than 95% of sensitivity, no additional testing is needed. Therefore, it effectively reduces the number of formal delirium assessments. Several more specific tools can be used in confirmatory tests. These include a brief confusion assessment method and the confusion assessment method, three-dimensional CAMP, and the 4A test. The brief confusional assessment method is the delirium assessment that can be performed under 3 minutes. It is simplified as CAMP ICU designed to improve sensitivity for delirium diagnosis in non-critically ill patients in demanding clinical areas such as emergency department. It uses objective testing to determine the presence of altered mental status, inattention, altered level of consciousness, and disorganized thinking. For delirium to be present, the patient must have altered mental status and inattention with either one of the latter characteristics. The brief camp is highly specific with performed by physician and non-physician ruling in more than 95% of patients with delirium. So the camp is most extensively studied and used delirium assessment instrument. As in the case with the brief camp, for camp to diagnose delirium, the patient must have altered mental status, inattentiveness, or either disorganized thinking or RAS other than 0. A recent meta-analysis evaluated the effectiveness of bedside delirium diagnostic tool demonstrated that CAMP has sensitivity and specificity of 86% and 93% respectively. Major drawback for the camp is that it might be time consuming and it takes approximately double the time of the brief camp. The disadvantages offset because nursing staff can repeatedly perform the test with adequate reliability. The high specificity and reliability lead to the broader and continuous delirium diagnostic tool that can perform several times throughout the day. 3D camp is the 3-minute delirium assessment that is based upon original camp algorithm. It uses both clinical and objective variable to determine the presence of delirium. As in the case with the CAM, the patient must be inattentive and altered with either of the other two clinical features to be CD CAM positive. Despite some modification to CAM tool, 3D CAM sensitivity and specificity are maintained above 90% in elderly population. 480 is the brief delirium and cognitive impairment assessment tool that can be used outside the ICU. It is easy to perform as it takes less than 2 minutes to complete. 480 is not based on CAMP algorithm and assign a score to 4 delirium and cognitive impairment clinical characteristics. This tool uses alertness without using RAS, 3 questions that measures cognition, attention, and acute mental status. After grading each variable, a score of 0 makes delirium or cognitive impairment unlikely, 1 to 3 makes cognitive impairment possible, more than 4 makes both scenario possible. Bellelli et al. Validated this tool in elderly patient population with sensitivity and specificity of 90% and 84% respectively. This score is very versatile and have been validated in acute stroke and culturally diverse elderly population. Now about prevention and treatment, delirium risk factors vary in ICU patients, thus an individual prevention and treatment strategy should be sought. Nonetheless, the three risk factors are consistently present because of clinical practice habit in most ICU. These are sedative, immobility, and sleep disruption. Therefore, these serve as important target for delirium prevention and treatment. Sedative administration is common among patients receiving mechanical ventilation. It is imperative to emphasize the two critical components of sedation management that can improve cognitive function. The first is performing coordinated daily sedation, spontaneous awakening, and spontaneous breathing trial. The second one is avoiding administration of benzodiazepine. Daily sedation interruption combined with spontaneous breathing trial has demonstrated improvement in the clinical variable associated with improved survival. In 2008, landmark study and awakening and the breathing control trial confirmed that their wake up and breathing protocol resulted in decreased number of days patient had acute brain dysfunction. Randomized control trial that demonstrated faster awakening time, fewer mechanical ventilation days among ICU patients sedated with alternative agent other than benzodiazepine. Only 3 studies have explicitly measured delirium as a clinical variable. Means that is maximizing the efficacy of targeted sedation and reducing neurological dysfunction trial randomized mechanically ventilated ICU patient to sedation with lorazepam versus dexmedetomidine for up to 5 days. It is found that patients with the dexmedetomidine group had a median of 4 more days alive and delirium free. A second trial compared dexam with midazolam. In the SEDCOM study, patients treated with midazolam had 23% higher delirium state. The ABCDEF bundle is one of the optimal methods to avoid delirium. ABCDEF bundle combines the several interventions that enhance the patient care. These include awakening and breathing condition for liberation from sedation and mechanical ventilation, choosing sedative that are less likely to increase risk of delirium, optimizing analgesia, consistent delirium assessment, prevention, treatment, early mobility, family involvement in patient care. ABCDEF bundle demonstrated improvement in multiple outcomes, including preventing and reducing delirium in the ICU. In addition to potential positive effect on delirium, individual component of ADCAF bundle are associated with numerous outcomes, including fewer mechanical ventilation days, shorter ICU and hospital length of stay, improved functional outcome, and mortality. Thank you, guys.